This you're seeing is a question paper of MBBS first professional exam, Anatomy, paper 2 of MBBS 2019 batch. This was conducted by this university. This question paper is from HNBGU University, Uttarakhand. This is Hemvati, Nandan, Bahuguna, Garhwal University of Uttarakhand, India. And as per my knowledge, there are 3 government medical colleges in this university. One is GMC Haldwani, then Doon Medical College, Uttarakhand, Dehradun, and GMC Srinagar also from Uttarakhand. So this exam was conducted on 6th of February 2021. So this question paper was of 100 marks, and out of that 100 marks, 20 this was section A, that is MCQ section, which had 20 MCQs of 20 marks. So here I'm going to solve these 20 MCQs for you all, so you can check your answers, and for those who are up to give their exams in future, they can revise from this for their MCQs exams. Okay, so the first question here was, which structure is intrasynovial at the knee joint? Choices are oblique popliteal ligament, tendon of popliteus, medial and lateral menisci, anterior cruciate ligament. So as far my knowledge says, actually this question is not properly framed. This question is not properly framed. So let me tell you why it's not properly framed. First choice says that is oblique popliteal ligament, and you know that oblique popliteal ligament is an expansion of the aponeurosis, or you can say the tendinous or insertion of semimembranosus outside the knee joint capsule posteriorly. It's an expansion from semimembranosus. So of course the oblique popliteal ligament is not going to be the answer in this, because it's both extracapsular, extra articular, as well as it is extrasynovial. So this is not the answer. Now talking about tendon of popliteus. Tendon of popliteus, you know, it arises from the lateral condyle of the femur, and it is intra-articular in origin. And this tendon of popliteus winds, and you remember it was also providing attachment to the peripheral margin of the lateral meniscus. So it's in its intracapsular course, it's intrasynovial as well, but when it comes out through this opening of the tendon of popliteus below the arcuate ligament, then of course becomes its extracapsular, extrasynovial. So that means the tendon of popliteus at its origin is intrasynovial. So this can be the answer. Then they have asked like intrasynovial structures, medial and lateral menisci. So medial and lateral menisci, let me tell you that medial and lateral menisci are, it's like this. There's less of space here. Medial and lateral menisci are actually, here you can see is tibia, and this is the capsule. So this will be the menisci here. Of course, this is from the tendon of popliteus and all. So remember, there's less of space actually Actually, this is how the synovial membrane is. That means the synovial membrane actually lines the two menisci at both its surface, like upper and surface and below surface. So that actually these menisci are actually intra-articular discs. Okay, so it divides the joint cavity into upper and lower cavities, and so the synovial membrane actually reaches to both the surfaces of the menisci, but then it is not intrasynovial, okay, because it's lined by this synovial membrane, so it is outside this synovial membrane. Then anterior cruciate, so this is not going to be the answer. So you have got to know that this cannot be the answer, this can be the answer, this cannot be the answer, or this can be answer. This is like I should say 50-50, because I'll tell you how. And anterior cruciate ligaments also I give plus and minus, it can or it may be. The reason is these two choices are like disputable. So this anterior and posterior cruciate ligaments, if I draw it here somewhere, let me draw it. And like if you're seeing the tibial plateau from above, so that I'm like taking a cross section somewhere. You can imagine that I'm taking a section in the middle of the knee joint, right? In the middle of the knee joint. So in the middle of the knee joint, what you'll find that the two cruciate ligaments, they come close together and they cross. Like this posterior cruciate ligaments ascends upward, forward, and towards the medial side as inserts on the medial condyle of femur. This tibial ACL ascends backwards, upwards, laterally to get insert on the lateral condyle of femur. So in the midway, if I'm taking a section, you should know this, that this synovial membrane is actually like this. So this actually is surrounded by synovial membrane, but saying that it's intrasynovial is wrong, because synovium is this. So anything within this will be considered as intrasynovial. So remember, ACL and PCL are also extrasynovial, but the problem is if you search on the books and in the net, and I took suggestions from various senior professors of anatomy and including professors of orthopedics, they come up with different opinions. There are a lot of different literature printed. People who are of who have been taught very early, like 20-30 years back, they are adamant on this ACL being intrasynovial. And what I think, because the answer exactly to this question must be in the mind of the teacher who must have framed this question, because they have not written PCL. It gives a hint that they might have selected this answer, but again it's controversial because a lot many books, a lot of many literature, even on the PubMed journals, they've written that both these cruciate ligaments are intracapsular but extrasynovial. So after a lot of discussion with so many professors, teachers, and internet scholarly articles, books, what I have drawn to this conclusion that the correct answer actually should be this tendon of popliteus. And but then again, this is not completely correct, as I told you that tendon of popliteus at its origin is intrasynovial, because part of the tendon comes out through this knee joint capsule, so not completely, but at its origin tendon of popliteus is intrasynovial. So according to me, I gave this B choice as the correct answer. Okay, next question is the esophageal opening in the diaphragm transmits all except vagal nerve trunk, right phrenic nerve, esophageal branches of gastric artery, veins, esophageal tributary of gastric veins. So what should be the correct answer? Well, you should know by now there are three major openings and the structures passing through each of the three openings in the abdominal this thoracoabdominal diaphragm. So you know that this right phrenic nerve actually passes through the vena cava opening that's in the central tendon of the diaphragm, right? Because phrenic nerve descends on the right side overlying the right border of this pericardium along with the pericardiophrenik arteries. So phrenic nerve, when it reaches down, along the right border of this fibrous pericardium, it descends down through the inferior vena cava into the abdomen. So the answer is right phrenic nerve. Remember this. Okay. 2, the answer is B. Then the small saphenous vein joins the femoral vein above the inguinal ligament, begins as the upward continuation of the lateral marginal vein of the foot, runs behind the medial malleolus, enters the femoral vein on its anteromedial side. So to select the correct choice. So now let me tell you that regarding the small saphenous vein, it joins the femoral vein not above the inguinal ligament, rather it joins the femoral vein behind the knee, right, at the level of this popliteal fossa, behind. Got it? So this is the wrong choice. Then it begins as the upward continuation of the lateral marginal vein of the foot is the correct statement. This is the correct choice. You can underline this also. Runs behind the medial malleolus. No, it should be the lateral malleolus. Enters the femoral vein on its anteromedial side. No, it enters femoral vein on its posterolateral side behind the knee. So your answer to this third question is B. Okay. Question number 4. Which of the following is not found within the femoral sheath? So they have asked not present in femoral sheath. This is an easy one. Femoral sheath, this is ASIS, pubic tubercle. This is femoral sheath. It has 3 compartments, right, like this. And the medial most compartment is called femoral canal. This is femoral canal, and there is lymph node, deep inguinal lymph node of Cloquet. This is ligament or lymph node of Cloquet. Then here is the middle compartment is external iliac vein. This femoral vein continues as external iliac vein and actually femoral vein. Then here in the lateralmost compartment is femoral artery, and there's a nerve that enters and pierces and becomes cutaneous, and that is femoral branch of genitofemoral nerve. And what lies lateral to this femoral sheath is the femoral nerve. This is femoral nerve. So for your interest, let me tell you that this femoral artery, where it passes the inguinal ligament, this point is mid inguinal point. This is mid inguinal point. and the point where this femoral nerve crosses the inguinal ligament, this is called midpoint of inguinal ligament. So mid-inguinal point is from where the artery crosses the inguinal ligament. Midpoint of inguinal ligament is from where femoral nerve descends down, and it is outside the femoral sheath. So your question here, which is not found in the femoral sheath, obviously the correct answer has also already been marked by someone, and this is femoral nerve. Fourth, your answer is C. Okay. Question number 5. The most medial structure passing under the inferior extensor retinaculum of the foot is deep peroneal nerve, tibialis anterior, extensor hallucis longus, anterior tibial artery. So let's revise this fast. Remember that at the front of the ankle there is this extensor retinaculum, and this extensor retinaculum is in two bands. The upper one is a transverse band, lower one is a Y-shaped band. So, and because the limbs of the Y is directed medially, let's say this is medial and this is lateral, right? So this is of the right foot, right leg, seen from the front. So medially, what are the structures passing? I believe you know the mnemonic here, that is the Himalayas. The Himalayas are not dry plateaus. This was the mnemonic. So structures passing, remember this medial most is tibialis anterior, and it passes through the two limbs of the Y. This is tibialis anterior muscle. The next thing that passes is this is extensor hallucis longus. This is extensor hallucis longus. Then it's this artery. This is anterior tibial artery, which actually becomes the dorsalis pedis artery. Dorsalis pedis artery here, and here it is called anterior tibial artery. The next thing that emerges out is deep peroneal nerve. This also passes through the limbs of the Y, and it emerges and then splits into its two terminal branches. So this is deep peroneal nerve. Then what passes below the stem of the Y is this extensor digitorum longus, and the last one to pass out is peroneus tertius. Got it? So in this question, remember, sometimes they might even ask this thing, so you should have this idea. What passes between through the stem of the Y is these two most two tendons. The rest of the structures pass through the limbs of the Y. Now let's see what they have written in the question. That anterior the most medial yes. Question number 5. The most medial structure passing under the inferior extensor retinaculum. Most medial structure, I had just draw the diagram. You had seen it. The answer will be tibialis anterior. The mnemonic begins with this T. The Himalayas are not dry plateaus. So tibialis anterior is most medial structure. So fifth, your answer will be B. Now question number 6. The anterior tibial artery pierces the interosseous membrane, supplies the lateral compartment of the leg, lies lateral to the deep peroneal lateral to the deep peroneal nerve, lies lateral to tibialis anterior. Now this is about the relationship of this anterior tibial artery. So once again, just have a fast look here. This is tibia. Let's say this is tibia, and here it is fibula, right? So this is tibia and this is fibula. So remember, from the anterolateral aspect of tibia, there is this shin. Remember, this is the shin. So here it is this muscle arising, and this muscle is tibialis anterior. Tibialis anterior. Then from fibula, this anterior border of fibula, right? Here will be anterior border of fibula, and from here this is upper 2/3. Let's say this is an F or toothbrush shape. This is a toothbrush shape origin of this muscle from the anteromedial surface of this fibula, and this muscle is extensor digitorum longus. Then from this middle 1/3, this muscle that arises here is extensor hallucis longus. And the last inferior portion of the lower 1/3, this muscle arising is peroneus tertius. Now talking about the artery and nerve. As I told you that there is this anterior border of the tibia, and to which there is an attachment of the intermuscular septum, and that is anterior intermuscular septum. So remember that common peroneal nerve was the nerve, the little winding along the neck of fibula. Then common peroneal nerve, actually, before that, let me draw this interosseous membrane. So the interosseous membrane here is directed like this, downward and laterally from tibia to fibula. And there is behind in the popliteal fossa, there was this popliteal artery. It was dividing into two branches. The major branch is the posterolateral artery, which goes into the back of leg, while this artery straight away runs in front of the interosseous membrane. And after crossing this, this is anterior tibial artery, and this, after crossing the extensor retinaculum, it becomes the dorsalis peris artery. Now about the nerve. So common peroneal nerve winds around the neck of fibula, and it gives its, the last branch from common peroneal nerve, remember, is one which winds fibula, ascends up to supply the knee joint, and that is this nerve is recurrent genicular nerve, and this is common peroneal nerve. So last branch from common peroneal nerve is recurrent genicular nerve. Then this common peroneal nerve divides into two terminal branches. One continues in the lateral compartment, that is superficial peroneal nerve, and the other one, this pierces this intermuscular septum. Then it pierces this extensor digitorum longus muscle, and then it continues like this in the leg and emerges like this lateral to the artery in the extensor retinaculum. So remember now about artery and deep peroneal nerve and anterolateral artery. So in the upper 1/3, the nerve is lateral, artery is medial. In the middle 1/3, the nerve overlies to the artery, and in the lower 1/3, again the nerve becomes lateral to the artery. That is the relationship of artery and nerve in the front of leg. But they have asked is about the relationship of anterior tibial artery. So here you are seeing that this artery is lying lateral to which muscle? Tibialis anterior, because this leg what I have drawn is front of right leg. So this is medial. So this artery lies lateral. And you can see that this deep peroneal nerve, right? Deep peroneal nerve lies lateral to the artery. Okay? So the artery lies throughout its course, you can say it's medial to the nerve. However, at this middle 1/3 artery, actually the nerve overrides to this artery, but along the entire length you can see that this is relatively medial to the nerve. So if you are You can, if you're seeing it, because I have to rub this, you can take a screenshot or you can pause the video to see it, the details. Now let's be back to this question. So this was about the antitibial artery, and you know what they have written is about piercing thing. So remember that the interosseous membrane is pierced by the peroneal artery, and that is the branch of posterior tibial artery in the back of leg. So this peroneal artery pierces this interosseous membrane in the lower 1/3, and then from back of leg it enters into the front of leg in the lower 1/3. Got it? So it's not this which pierces. So this is a wrong statement. Supplies the lateral compartment of the leg. No, you just seen it. That is an artery of the front of leg, and lies lateral to the deep peroneal nerve. You've just seen it, that the entire course the artery is medial to the nerve and lies lateral to tibialis anterior. So this will be the correct answer. So your question number 6, the answer is D. Okay. Then question number 7, a midline abdominal incision below the umbilicus passes through all of the following except pyramidalis, linea alba, extraperitoneal fat, transversalis fascia. So here they are talking is about midline subumbilical incision. So let's presume that this is the anti-abdominal wall and here this umbilicus, and what they're talking is about this incision, right, below the umbilicus. And now let's take a cross section of this, so you'll get to know what are the structures piercing. So here you seeing is the anterior abdominal wall. Let's say this is the umbilicus, right, cut section. So, and you know this this is rectus abdominis. This is rectus abdominis. So, and you know that this external oblique aponeurosis is like this, covering the front, and then you have internal oblique aponeurosis which splits to enclose this, and this is actually the formation of femoral sheath in the middle portion at the umbilical portion. And then there is this transversus abdominis, the aponeurosis. So the green thing here, this is like decussation of the fibers, like aponeurosis of this internal oblique and all this, the fibers here together. Now this merged together, and this is called linea alba. Got it? And now what lies behind to this is fascia, and that is called fascia transversalis. Fascia transversalis. And what lies deep to that will be the peritoneum. Now this is blue color is peritoneum. What lies between fascia transversalis and peritoneum will be this thing, and this is extraperitoneal fat. Extra means outside, extraperitoneal fat. This is extraperitoneal fat. If you're going to give an incision, now look here, if you're going to give an incision here, what will be the structures cut? By the way, I have not taught you about the pyramidalis in this. So remember, in this diagram above, let me draw that also. Here you have pubic symphysis, and you have iliac crest. This is the inguinal ligament, everything, you know. And the incision what I'm drawing is through this line, and this line is linea alba, right? So pyramidalis actually takes origin from the front of this body of pubis and is attached here on the linea alba like this from both the sides. So this is a triangular muscle, a pyramidal muscle, that's why it's called pyramidalis, and it is supplied by subcostal nerve T12. So the purpose actually is presumed that is meant to pull and make this, you know, linea alba taut. Rather, it's supporting the rectus sheath and making it, like, you know, strengthening this rectus sheath. That is supposedly the action of pyramidalis. But remember that it is not in midline, right? From pubis, it is both the sides attached to this linea alba. So when you giving an incision here, so what are the structures being cut? Linea alba will be cut, then fascia transversalis will be cut, then extraperitoneal fat will be cut. If it goes further deep, then peritoneum. Got it? So what will not be cut is pyramidalis. This should be the answer. Okay. Midline incision below the umbilicus passes through. They have asked passes through all of the following except. They have to ask this except. So the answer will be pyramidalis. So for 7th question, the answer is A. Question number 8. Question number 8 is, the spleen has a lower pole which normally projects forwards to the anterior axillary line. Listen carefully. Lies between the 8th and 10th ribs, has a long axis lying along the line of the 9th rib. It is as it enlarges, glides in contact with the anterior abdominal wall in front of the splenic flexure of the colon. So again, a fast revision. If you are seeing this, let's say a drawn is the body like this, human body like this, and this is the rib cage, right? So let's say this is 9th, 10th and 11th ribs. Of course 11th rib does not reaches to the xiphisternum, so let me draw it a little more correction. So I think this much you can understand. This is 11th rib, 12th rib is this. So spleen, now spleen actually lies here. This is the location of spleen, and this is sternum here. So this is 9th, 10th and 11th ribs. So you got to know that spleen is lying between the 9th, 10th and 11th ribs, and 10th rib lies along the longitudinal axis, and the spleen lies along the longitudinal axis of this 10th rib. Okay, and it is of course directed downwards. If you see in this view, there's a spine here. These are the, you know, right, this is the 11th rib. So spleen is placed here like this, right, and the longitudinal axis of the spleen is like this with the spine, and it makes an angle of around 45 degrees. Got it? And now look here, this question has to be solved. Actually, this is presumed to be axilla, cut section of the axilla. Now if you draw a mid axillary line, you will find that this is the mid axillary line, right? So this is mid axillary line. So you're seeing that this mid-axillary line actually passes to the anterior border or the inferior pole of this anterior pole of this spleen. Got it? Now about the relations. So remember that spleen is lying here somewhere, as I have shown it here. So spleen is lying like this, right? Then much of this portion of the spleen above is related to the stomach, right? It is related to the stomach, and lower portion posteriorly is related to this portion here, is related to the left kidney. This much portion is related to the kidneys, and this portion is related to the stomach, right? And then here you seeing is the pancreas, right? So this is the tail of pancreas. This will also be related to the spleen. And don't forget, under to the pancreas there will be the splenic vein, and on the upper border of this pancreas there will be a tortuous splenic artery. And now at the lower end here will be a flexure of colon. This is the splenic flexure of colon. And one more important thing you can remember here, because behind posteriorly is the diaphragm, like this is the diaphragm here posteriorly, right? So this is all diaphragm behind. So what will happen now, this the splenic flexure of the colon is actually held with this infradiaphragmatic fascia. So this is actually a full diaphragmatic portion, the peritoneum. So this spleen, this transverse colon is suspended by mesocolon. So a band of 5 peritoneum which binds the splenic flexure of the colon to the diaphragm, and this is called phrenicocholic ligament. So this phrenicocholic ligament actually limits this space here. This space here side mein, on the left side of this colon, is called paracholic gutter on the left side. So this place is left paracholic gutter is limited above because of this horizontal. Remember, this is on a horizontal fold of peritoneum, and that is called phrenicocholic ligament. Then what else they wanted to know? Yeah, about this increase in size, like when it grows, what happens? So here you seeing is, as I've already shown you, this is the spine, this is the 9th rib, this is the 10th rib, this is the 11th rib, and you have a spleen here. This is how the spleen is placed here. And remember that the anterior pole reaches in the mid-axillary line. Now what happens if it starts growing, and I have already drawn that here, it is this colon, splenic flexion. So what happens if this starts growing, and you can let me draw it again, that this becomes the anterior abdominal wall. There is this umbilicus, here it is ASIS. So the direction of growth of the spleen will be, it will grow like this over to this colon, over to this splenic flexure of colon, under to the skin, like this splenomegaly can be easily palpated and can be felt below the skin. Below the skin means below all the structures of the anterior abdominal wall, and they will grow in the direction of the 10th rib. So in the direction of the 10th rib, this spleen will elongate and will gradually keep growing towards the umbilicus, and ultimately it will be directed towards this right iliac fossa. Sorry. So it reaches on the right iliac fossa. That is the pattern of growth of spleen, right? First of all, it will cross the splenic flexure of the colon, then it will move towards the umbilicus. Further in its growth, it may reach to the right iliac fossa. right? So I believe if you understood all this, you can take a screenshot. And now let's go back to the question. The spleen has a lower pole which is normally projects forward to the anterior iliac axillary line. No, it is, I just told you that the anterior border of the spleen reaches maximum up to the mid axillary line. It is mid anterior nahi hoga ye, this will be mid axillary line. So this is a wrong statement. Then lies between 8th, no, I just told you it's between the 9th to 11th ribs. So this also is a wrong statement. Has a long axis lying in the line of the 9th rib. No, I told you it lies along the 10th rib. As it enlarges, it glides in contact with the anterior abdominal wall, remember, in front of the splenic flexure of colon. So I have just explained you everything about this. So the answer to this question will be this, right? So the D choice is the correct answer for question number 8. Question number 9 is, which is the most common site for appendix found in the appendicectomy? Well, I have to tell you a lot enough about this, but I am not going to explain because this video will become very lengthy. So in brief, I can tell you something like this, that is the cecum, the most widest portion of the large colon here, and which is more in width than height, and there you find is this opening of this ileum, remember, and here you have a valve. What is this valve called? This valve is called TULP, Tulp's valve. Remember, ileocecal valve is also called Tulp's valve. And a little below to this, around 2 centimeters something below to this, you find is another opening, and onto which there is attachment of this appendix. So there might be appendix like this, there might be appendix like this. These two I have drawn the common positions of the appendix. First of all, let me tell you that this opening at the appendix, opening of appendix in the cecum is called, you have a valve, and it's called valve of Gerlach's. This is called valve of Gerlach's, LHCH, valve of Gerlach's. Now the positioning of this appendix is like this clockwise. If you say this position here is 12 o'clock position, 12 o'clock position is the most common position, and that is retrocolic. This retrocolic is also called as retrocecal. Retrocecal or retrocolic is the same word, and 12 o'clock position, and remember this is the most common, and it is around 65% of the subjects we find this type of position. And then you have this another position, and this position is the next common position is pelvic position of this kidney or of this appendix, and this is at 4 o'clock position, and this is 30% present in the subjects. Rest other are like pre-ileal, post-ileal. These two are directed 3 o'clock and reaching towards the sacral promontory. You can also call it a promontoric position, and you have a position directed downwards, like this below, and so this is called subcolic or subcecal, or it reaches to the mid-inguinal point, so it is also called as mid-inguinal in position, right? So these are the different words for this, and it is 6 o'clock position. Obviously the percentage is only 2%, right? And there is another position of this appendix reaching here, and which reaches on the right side of the cecum, so that will be the right palacolic gutter. So you can remember this position of the appendix, if it's there at 9 o'clock position, this is paracolic in position. It's called paracolic. 9%. This is 2%. This also is 2%. This is 9 o'clock position. Take. Just for revision, I have taught you all important points. Remember that the answer to this was very easy. So it is retrocecal. So remember that it may be asked as retrocolic or retrocecal. So is the most common. 65% subjects may you find this. Position is 12 o'clock position. So question number 9, answer is B. Question number 10, the abdominal aorta. The abdominal aorta passes into the abdomen behind the diaphragm at the level of the 10th thoracic vertebrae. This is a wrong statement. By the way, I have in my channel, in the playlist, if you see, there's a complete detailed lecture on abdominal aorta. So if you want to know the details of the abdominal aorta, go and watch the lecture in my abdominal playlist. This is the wrong answer, right? Because it passes through the 12th thoracic, at the level of the 12th thoracic vertebrae, it pierces the abdominal diaphragm at the level of T12. Then it bifurcates at the level of the body of second lumbar vertebrae. No, this should be fourth lumbar vertebrae. So this also becomes the wrong statement. Then abdominal aorta passes into the abdomen behind diaphragm at the level of 12th thoracic vertebrae. So this will become the right answer. Gives rise to the celiac artery at the level of the lower border of the 10th thoracic vertebrae is again wrong. It gives at the level of lower border of T12. You find is the celiac trunk. So you have got the answer, that the answer to this 10th question is C, is the right statement. Okay. Now question number 11. Length of ureter is about, it's very easy, simple. It is 25 centimeter, remember, which is equal to 10 inches, right? So out of this 10 inches, 5 inches is abdominal portion, and 5 inches is pelvic portion. Okay. There are other structures like, esophagus, stomach, duodenum. They are all of 25 centimeter or 10 inches. Question number 12. Fascia transversalis contributes to which of the following structures on the anterior abdominal wall? Fascia transversalis. I just talked about this fascia transversalis, if you remember, while I was discussing about the midline subumbilical incision. So remember now, superficial inguinal ring. This is a triangular gap in the external oblique aponeurosis. So this becomes the wrong answer. Deep inguinal ring. Remember, deep inguinal ring is an opening in the fascia transversalis, right? And this opening lies above the mid-inguinal point, about 1.2 centimeter of the mid-inguinal point. That is this opening, oval opening, and this opening is just a little lateral to the stem of the inferior epigastric artery, branch of external iliac artery. So this will be the answer. By the way, inguinal ligament, remember, it is the folding of the lower portion of the external oblique aponeurosis. So this is the wrong answer. Then sac of indirect inguinal hernia, obviously this will be the fold of peritoneum. So your answer is 12B. 13th, question number 13 is, lymph from glans penis drains into external iliac lymph node, internal iliac lymph node, superficial inguinal lymph node, deep inguinal lymph node. Now, this question also has not been properly framed. There's problem in this question that because they've asked lymphatic from the glans, right? So remember that the lymphatics from the glans penis drain into both the external iliac lymph nodes is also correct, and deep inguinal lymph node is also correct. So this is not a good question, not properly framed. But I know why it has been framed, because most of the teachers and most of the, for this first year undergraduates, basically you must have been taught about the deep inguinal lymph node of Rosenmuller clock weight. I think for that purpose, this has been framed. And as I said, such disputable questions, the answer to this question lies in the mind of the teacher who has framed this question paper. So, for your answers, okay, let me explain this fast for you, because in future you may come across this again. So let's draw it for you. This, let's say, is a penis, and within the penis you have these corpora within this, and you also have the two corpora cavernosa and a median corpora spongiosum, corpora cavernosa and corpora spongiosum. And this becomes this is the glans. Okay. So about the lymphatic drainage of the penis, remember I am telling you the details. You might come across such questions in future. So write it down, that the glans, lymph from the glans, lymphatic drainage of penis, right? This is important. So lymph from the glans, remember, it drains into external iliac lymph nodes and deep inguinal lymph nodes, and this is present in the femoral canal, and there you have this lymph node named as lymph node of Clockwitt, or this is also called as lymph node of Rosenmuller. Now about the lymphatic drainage of the skin of the shaft of penis. So lymphatic drainage of the skin of the shaft of penis, this I'm talking. This, remember, is skin of the shaft of penis. This will drain into the medial group of superficial inguinal lymph nodes. That's not only this, but rather the entire, the skin, the perineum, most of the peritoneal structures, the skin, the scrotum, right, labium majors, perineal area, most of this, perineal structures, and in the drain here in this superficial group of inguinal lymph nodes, the medial group. Then about this lymphatic drainage from the corpora cavernosa, corpora spongiosum, this will drain into internal inguinal lymph nodes. So take a screenshot. This is important. You should remember this. Many questions come upon this lymphatic drainage from the penis. Got it? So then again, the answer again I would say is disputable, but presumably being, because of the first year undergraduates, and very commonly you are asked about lymph node, Rosenmuller, clockwood, femoral canal. This topic is a hit topic. So if you have marked this, I think you would get good marks. I mean, you'll get it correct. But again, I would say this is also the answer. Okay, so that was question number 13. Now question number 13 answer will be both A and D, but chances of you getting it right in your exam, I suppose, should be D. Okay, now about 14, question number 14. Meckel's diverticulum is due to persistence of allantois, vitellointestinal duct, left umbilical vein, ductus venosus. This is just for a revision. Remember, this is how this intestinal loop, after being herniated out, it comes out. Then this duct of patent vitellointestinal duct actually remains there, and sometimes what happens, this after 6 weeks, normally around sixth week of intrauterine life, it disappears. But if due to certain conditions, if it fails to disappear, what will happen now, that you will find that this gut has this type of bulging diverticula, and here, as I was telling, that there is this anterior abdominal wall, right? And what will happen now, that this point was umbilicus, from it was coming out, so there will be a fibrous strand connecting it to the umbilicus. Now the important points about this, remember the formula of 2 for Meckel's diverticulum. This is Meckel's diverticulum, formula of 2, that is present in 2% of the subjects. 2% of subjects, one thing. Then it is 2 inches in length. 2 inches in length. Then it is 2 feet. 2 feet. I mean, 2 inch will be equal to 5 centimeter. Don't get confused in an exam, they change it. So 2 inch is equal to 5 centimeter is actually its length. 2 feet, or you can say 2 feet is equal to 60 centimeter proximal to the ileocecal junction. Okay, 2 feet proximal to ileocecal junction or ileocecal wall. That's the formula of 2 for this. Then it is present on the Yes, so I was telling that this is present on the anti-mesenteric border. Anti-mesenteric border is one point. Then about this, that this fibrous strand, you may or you may not find, it may be connected to the umbilicus, or it may get connected with this fibrous band to the mesentery or to some other structure, and it will become a cause of obstruction of the loops of intestine. So those are some important points about this Meckel's diverticulum. And remember the lumen जो होता है इसका, lumen of this Meckel's diverticulum is same as that of ileum. Okay, so the answer to this is vitellointestinal duct. 14th answer is B. 15th, question number 15th. The tubercle of a typical rib articulates with the facet on the transverse process of vertebrae, above vertebra, below its own vertebrae, or all of the above. So again, let's see this. This is a transfer. This you're seeing is a vertebrae, and then you have a vertebrae. Oh, hold on, let me draw it properly at least. So you have this vertebrae, thoracic vertebra, like this is the transverse process, and you have a vertebrae above. So each vertebrae has a costal facet. Remember that the upper costal facet of a vertebrae is large and the lower costal facet of a vertebral body is smaller. Now talking about the head of the ribs. So head of the rib also has two costal facets, right? And here you have the transverse process. So this is how it is. It is, hold on, articulates first rib. hold on, फर्स्ट रिब जो है वो फर्स्ट रिब किससे जुड़ेगा? फर्स्ट रिब फर्स्ट वर्टिब्रे से जुड़ेगा, है ना? फर्स्ट रिब जो है सेकंड रिब जो दोनों जो जुड़ता है इट्स ओन करस्पॉन्डिंग वर्टिब्रे. So here you are seeing that this is the rib I have drawn. It's like this, and this is like this. So this transverse process, when it reaches behind, there actually it articulates with the tubercle, there like this. So each rib actually articulates with its numerically corresponding vertebrae. Let's say if it's sixth rib, so this will be the sixth vertebrae, and a part of it, its head, will articulate with a vertebrae above. So remember, this transverse process is of the numerically same vertebrae or numerically corresponding vertebrae. So the tubercle of a typical rib articulates with the transverse process of its own vertebrae. Okay. Apex of heart is formed by, there's a short video on this in my playlist in the folder of specimen viscera. They will find a lecture on this apex of heart. They have taught you that the apex of heart is formed by the left ventricle. It's easy. Then 16th D हो गया. 17th, enlargement of which organ may compress the obturator nerve? Yes. So which organ, when it enlarges, compresses upon? So remember that there is this external iliac and common iliac, external, this is internal iliac, right? And from internal iliac there is this branch, this is external iliac, this is common iliac, this is internal iliac, right? And this is superior vesicular artery. Remember, superior vesicular artery was continuing as the umbilical artery in fetus. Now, and there is this obturator artery also running like this. This is superior vesicular artery, this is obturator artery, and there is this nerve passing, and this is obturator nerve. Now this space you are seeing in the lateral wall of the true pelvis, this space is called ovarian fossa, and here you find is the ovary placed. So this ovary is placed here, overlying to or compressing the obturator nerve in its lateral relation. Right? So the answer will be, it's easy now for you. So the answer to this will be ovary. Enlargement of which organ may compress the obturator nerve? The answer will be ovary. 17th will be C. Question number 18. Within the anal canal, location of internal hemorrhoids are. Location of internal hemorrhoids. I believe this is an easy question, because this normally, this position in the clockwise position, remember, is taken in lithotomy position. Lithotomy position. So in lithotomy position, remember, the the internal piles or the primary piles you will find around the 3 o'clock, 7 o'clock and 11 o'clock. 3 o'clock, 7 o'clock, 11 o'clock. So this is the answer, right, within location of internal piles in lithotomy position. This again question I would say is not properly framed, because they have not mentioned the position. If you take in a knee elbow position, this clock thing will change, right? If you take this in a left lateral position, a Sims position, this clockwise position will change, right? So again I would say this question is not properly framed. They should have written it in lithotomy position. Okay. Then transitional epithelium is present in. So easy, super easy. Transitional epithelium. What is the another name from transitional epithelium? You know it. It is also called as urothelium. Right? So urothelium is present in the minor calyx, major calyx, renal pelvis, ureter, urinary bladder, prostatic, urethra. This all thing here you're seeing, remember all these examples, it's where you'll find is urothelium or transitional epithelium. Okay? So in this question your answer will be ureter. Trachea, jejunum, liver, ureter. Answer will be ureter. Last question again I think is easy. Its Y-shaped ligament of hip joint is ischiofemoral, iliofemoral, pivofemoral ligament of head of femur. Again I would say this should have been better framed if they would have written inverted. This question would have been better framed if they were written inverted Y-shaped ligament of the hip joint. Then your answer is iliofemoral ligament of Bigelow. And this is the strongest ligament of body, human body. Okay. So it's done.